All right, so Dr. Hayley Merkeley, it's a pleasure to introduce her. She is a hematologist who completed her training here at is that right? Yeah, the UBC and U of T. How come I have and U of T? Yeah, I did. There you go. That's right. So she did some further training in hemoglobinopathies there. She's the medical director of the Provincial Red Cell Disorders Program at St. Paul's Hospital, as well as the co-director of the UBC Hematology Residency Training Program. She has really, with Shannon Jackson, as you've seen, created this first classical hematology fellowship program, which is obviously off to a fantastic start. She has broad interest, particularly in sickle cell disease, thal, ITP porphyrias, and global health, indeed. So I'm really pleased that she's here today. Hayley.
Thanks to Ed and to the CBR for having me, and I'm really pleased to talk about one of my favorite topics, which is sickle cell disease. So I'm hoping we'll discuss the burden of sickle cell disease, describe the current Canadian therapeutic landscape, and highlight novel therapies with a focus on commercialized gene therapy, including Casgevy, which was mentioned. So these are my disclosures. So what is sickle cell disease? Well, it's actually a monogenic disorder. It results from a single point mutation in beta globin. So in place of in place of glutamic acid, you have valine. And this leads to a conformational change in hemoglobin. In hypoxic conditions, the hemoglobin will abnormally polymerize, distort the red blood cells, which leads to three main pathophysiologic consequences. So number one, there's vaso-occlusion. These cells do not flow through the vasculature well. This leads to a state of chronic hemolysis. The average lifespan of a sickle cell is 15 to 20 days, and this leads to a state of vasculopathy in multiple vascular beds. This mutation results from selective pressure from malaria, so it's very common in parts of the world where malaria was systemically endemic, namely sub-Saharan Africa. There's a heterozygous state called trait, and patients can have homozygous or be compound heterozygous for other beta globin mutations, which leads to a disease state. Globally, around 8 million people around the world live with sickle cell disease. There's 5 more times carriers. 90% of the world's population lives in 3 developing countries, and sadly, most of the world's population will die of sickle cell disease before they reach 5 years of age. It's a highly stigmatized condition in the developing world. Patients are often identified by the presence of yellow eyes or scleral icterus and can be shunned from their communities and families. Access to treatment is and even diagnosis is extremely limited in the global setting. In Canada, we have about 8,000 people living with sickle cell disease. Historically, it's always been rooted in Eastern Canada, where there's larger African ancestry populations, but we are certainly seeing a huge influx in Western Canada. In fact, 13% of new immigrants to Canada are arriving from an African country, so that's significantly increased the rates that we're seeing here. It's now the most common rare disease in Canada, and historically, there's been funding disparities for sickle cell disease compared to other genetic ancestries affecting people of European ancestry, like cystic fibrosis. So this is just to highlight the growth that we've seen in our Vancouver program in recent years. So when I joined the program in 2018, we had around 50 people. That's now tripled. We've got 150 patients, new referrals coming in all the time. So how does sickle cell disease affect our patients? I like to think of it as an accelerated aging system, and as my patients are probably very sick of me saying, it is not a fine wine, it does not get better with time. There are a lot of serious complications and devastating complications, so strokes, patients can have liver failure, they can have renal failure, but the hallmark of the disease is frequent painful crises that are bringing them to interface with our acute medical care system. My diagram doesn't quite do it justice. I think it's more powerful to hear from a patient. So this is a patient of mine. He's actually a physician himself. He's 46. He lives in a community outside of Vancouver. He's tried multiple therapies for his sickle cell disease over the years. Most recently, he's on hydroxyurea, which is our mainstay of treatment that I'll talk about, and is on a clinical trial with a pyruvate kinase activator called etavopivat. And so this is just some things that he expressed to me about living with pain. So I live with chronic pain daily. I only very reluctantly go to the ER. The ER doctors believe I am addicted or dependent on opioids, and keep in mind this is a doctor himself. My practice was forced to change because I can no longer do hospital-based medicine because of the pain. I've been offered anticoagulants instead of opioids, which just belies a gross misunderstanding of the disease pathophysiology from healthcare providers. We know that sickle cell disease is associated with early mortality. So a recent study estimated life expectancy at around 54 years of age. But when you adjust that for quality of life, you can slash off a further 2 decades. These patients are also very expensive to care for our medical system. So the direct medical costs of caring for a single sickle cell patient approaches nearly $2 million over the course of their lifetime. And as I've highlighted, their quality of life suffers. This is looking at patient-reported quality of life outcomes. So in the green are pediatric patients. And so before they've accumulated a lot of disease morbidity, they're kind of on par with having a cancer patient on chemotherapy. But on the bottom, in the yellow, once they've aged and become adults and have a lot more of the morbidities associated with the disease, their quality of life is actually worse than a patient on active chemotherapy. So what can we offer our patients? Well, transfusion is still a very big component of what we do. Most of the transfusions we offer are episodic, but many of our patients are on regular transfusions as well. And many of those patients actually receive red cell exchanges. That, of course, has limitations. Patients often have challenging vascular access. We need a specialized center to deliver that. Here in BC, the only center that can do it is Vancouver General. Many of our patients are heavily alloimmunized or have rare blood types, so sourcing blood for them is highly problematic. Hydroxyurea is really the backbone of our treatment, so it's an oral tablet that patients take daily. It's got many mechanisms of action in sickle cell, but the main one is induction of fetal hemoglobin. It has been FDA approved since 1998, but it is still an off-label indication in Canada. There's L-glutamine that you may have heard of. It's marketed in the US as Endari. It's pharmaceutical-grade L-glutamine. It was FDA approved in 2018 on the basis of having some improvement in hemolytic parameters in these patients. It has not been Health Canada approved. There's no access program for patients to receive it. Even if they wanted to pay out of pocket for it, it's about $25,000 per year for an amino acid. Crizanlizumab is a molecule that it's a monoclonal antibody targeted against P-selectin, which is present on platelets and endothelial cells. It received FDA approval in 2018 on the basis of a phase 2 trial that showed a reduction in vaso-occlusive crises, reduction in hospitalizations, and lengthening in between vaso-occlusive crises. So we did have access to it through a compassionate program through Novartis. Unfortunately, there's recently been a phase 3 trial that was published that did not show the same benefit, and so it's likely that we will no longer have this access program. Again, if our patients wanted to pay for this out of pocket, it's $88,000 per year. The final molecule that I'll mention is called voxelotor. So it is approved in the US. What it does is it stabilizes hemoglobin S in the non-polymerized form, and that has been shown to improve hemolytic parameters. We haven't seen any clinical endpoints thus far, but it is available, and recently we now have a new access program that's opened up through Pfizer, so we're hoping we may be able to get a few patients on this. But in summary, there are really no Health Canada approved therapies for sickle cell disease. So we can also think about curative therapies. So hematopoietic stem cell transplant has been used for decades in this condition, and certainly matched sibling donor transplants are becoming standard of care for pediatric patients. We know that the optimal age for transplanting patients is less than 14. Unfortunately, only 15% of patients will have a matched sibling donor. We recently had a presentation from our colleagues in Calgary who really are leading the country in transplanting adults with sickle cell disease. And with some of the newer protocols, they're actually seeing quite good outcomes in their adult patients. So for matched sibling donors, they're seeing event-free survival of around 90% and around 80% for haploidentical transplants. Then, of course, there's gene therapy, the other curative therapy, and this certainly has some clear advantages over transplant. So number one, there's no worry about graft versus host disease because you're using the patient's own cells. You don't have to worry about finding a donor. There still are issues with graft failure. Because of the conditioning chemotherapy that this therapy still requires, there are issues with infertility, therapy-related malignancies, and with these therapies, there is still a risk of increased complications the older you are. Where transplant is a clear winner over gene therapy is in terms of cost. So at least in the US, the two commercially available therapies are going to be marketed within the range of $2 to $3 million per patient. So gene therapy for hemoglobinopathies currently all have the same recipe. So it's a myeloablative chemotherapy followed by a cellular therapy product that's been manipulated ex vivo. And there's a few phases that we have to go through to deliver this therapy. So number one, we have to optimize the patient's stem cells. So marrows in sickle cell disease are very inflammatory. And so it's not a great environment for stem cells to thrive. So typically these regimens involve red cell exchanging patients to lower their sickle hemoglobin percent to less than 30 for at least 2 months prior to collecting the stem cells. We then have to mobilize their stem cells from the marrow and collect them. The typical agent we use, G-CSF, is contraindicated. There's a black box warning on it for patients with sickle cell disease. So we have to use a much more expensive one called plerixafor. Then this therapy is produced. Depending on the therapy, there's different ways that it's manipulated. The patients then have to receive conditioning chemotherapy that, as of present, is completely myeloablative. It usually takes about 10 to 12 weeks to create the final cellular therapy product. We infuse it, and marrow reconstitution takes about 35 days. So this, of course, requires a transplant center in order to facilitate all of this. In terms of different targets, there's kind of three main approaches that the different gene therapies are using. So you would think that with a monogenic disorder, we would go right for gene correcting, but due to technical limitations and commercializability, that has not been the standard approach as of yet. So the first therapy I'll talk about, which is from Bluebird Bio, is a gene addition therapy where they are adding a non-sickling hemoglobin. The second approach is a gene silencing therapy where we're targeting a repressor of fetal hemoglobin. So the Bluebird Bio product is called Lovocell or Lyfgenia. This was initially started with marrow collections. They've now moved to stem cell collections. The product is then manipulated by using a lentiviral vector that inserts this non-sickling hemoglobin. The patients undergo their myeloablative chemotherapy, and we wait for engraftment. They actually tried to market this in the EU. They got EU approval in 2019, but unfortunately failed to come to an agreement with payers, so they withdrew their product from the market. So it's only going to be marketed in the US as of yet. I doubt they have any plans of coming to Canada. There were some controversies with this therapy. In the first iteration of it, they were seeing issues with acute myeloid leukemia. They've subsequently revised it, and those issues have not been seen, but this remains a risk that we worry about with these therapies. The second therapy, Casgevy or Exocel, is marketed by Vertex Pharmaceuticals. As we mentioned, it's currently under submission, under review by Health Canada. Both of these products can be used in thalassemia and sickle cell disease. Currently, Casgevy has been approved in the US, the UK, the EU, Saudi Arabia, and Bahrain, and we're hoping that Health Canada will approve it as well. So the target of this is BCL11A, which is a potent repressor of fetal hemoglobin. So similar to hydroxyurea, if we are able to induce fetal hemoglobin, we can significantly modify the phenotype of sickle cell disease. So again, it's the same old recipe. You collect some stem cells, you manipulate them ex vivo. In this case, we are using electroporation to deliver a CRISPR-Cas9 editing tool. The patient then undergoes myeloablative chemotherapy, and the cellular therapy product is infused again. So the main endpoint that they were looking at in their trial was something that they called VF12. So this is freedom from vaso-occlusive crises for 12 consecutive months. And 96.7% of patients met this outcome. So significantly modified the disease. Unfortunately, the longest patient has about 4 years of follow-up, so, but thus far, it does seem to be durable. So we can see here that the bottom graph is the fetal hemoglobin. And by inducing fetal hemoglobin, we were able to significantly increase total hemoglobin. So the average sickle cell patient would typically have a hemoglobin in the 70s, 80s. These patients were getting hemoglobins of like 120, 130. We know from patients on hydroxyurea that when you have a fetal hemoglobin percent of 20, that's significantly protective. In this trial, the average fetal hemoglobin level was 44%. We also know that it depends on where the fetal hemoglobin is distributed in the red cells. So if it's heterocellular, that's less protective than if it's pancellular. And in these patients, we saw pretty much a universal pancellular distribution of fetal hemoglobin. This product does seem to be stable, so when we look at bone marrow and peripheral blood allelic editing percent, you can see that there is stability over time. Most of the side effects were felt to be related to the conditioning chemotherapy itself rather than the gene therapy product. So things that we would expect: nausea, stomatitis, vomiting, febrile neutropenia. There was one death in this trial, but that was related to a COVID-19 infection. So there's still a lot of unanswered questions because that follow-up period is so short. What are the long-term side effects of gene therapy? We worry about off-target effects, insertional mutagenesis. How is this durable over time? How are patients and healthcare systems going to afford this? And how are we going to ensure equitable access for patients? Myeloablative chemotherapy is associated with a loss of fertility. So this is a big issue for our young patients who hope to start families one day. How are they going to preserve their fertility, and how are we going to pay for that? So the kind of holy grail that everyone's looking to is when coming to a point where we may be able to deliver these in vivo, so patients will not need a transplant center. Where we can have less toxic conditioning, where they may be able to preserve their fertility. And ultimately, we want to be able to deliver these to low and middle income countries where really the burden of disease is. And I would be thrilled if these therapies could put me out of a job. But I think just due to the burden of this disease globally, our immigration patterns, we will never be short of business. And with that, I'm happy to take any questions you may have.
Is it absolutely necessary to use myeloablative therapy?
Yes, so we have found that with non-myeloablative regimens, there's more graft failure. And one of the and they've experimented with like lower cell doses and things like that. When we see that, there seems to be more stress erythropoiesis in when the marrow is reconstituting. And that seems to be one of the drivers for leukemogenesis that we see. So the patients that developed AML, those were the ones that had, lower cell doses, that had lower doses of chemotherapy. So yes, at this stage with the current therapies, we do seem to need full myeloablation.
Can I ask a second question, which is sort of related? Given this is a non-malignant disease, but requires a treatment which is typically used to treat malignant disease, what would be your strategy in terms of funding? Which pocket is it going to come from?
Yeah, so this is the question that we were asking the group in Calgary recently. And they basically take the approach of, they tell their funders that this is a patient that needs a transplant. They don't exactly highlight the specific disease. And I mean, they're doing, 2 or 3 a year, so it's not a huge part of their budget. And they just push the patients through, and thus far, no questions have been asked. But I mean, you think about, these are patients who are very young, who have their entire lifetime ahead of them. I mean, the cost effectiveness of transplanting these patients versus a 60-year-old AML patient, where you have, for sickle cell, the opportunity, 96% chance of curing their disease versus, what is it for AML, 50%? For most comers with AML, there's a huge cost effectiveness argument to be made for this.
Hello. Fantastic talk. Thank you so much. I just have a question about, it seems that Health Canada approval for drugs really lags behind FDA approval. Is there a reason for that?
So, yes. So there's a few reasons. So the pharmaceutical companies have to submit, a separate approval package. Often many of them don't, because we're a smaller market. Why would they go through the rigmarole of submitting this, paying the fees that they have to Health Canada when there's going to be so few patients on it? Their bigger markets are the US and the EU. So that's one issue. And there are a lot of bureaucratic hoops within Health Canada. This is often where patients with rare diseases in Canada get kind of screwed because, for example, we've had patients who participated in clinical trials, and then the company decides that they don't want to bring the product to market in Canada, which, is completely unethical. But there's nothing forcing them that they have to do it.
You pass? I do have a question or a comment. First, malignant, by a non-medical definition, this is certainly a malignant disease. Can you just speak to the question of opioid dependence? And I mean, because it is bandied around a lot, is there a high risk of opioid dependence in these patients, and how is it managed?
So what we know about pain in sickle cell disease is there's many different types of pain, and we're not good at differentiating. There's acute vaso-occlusive pain, which absolutely, I mean, your bones are literally infarcting. As you can imagine, that's an exquisitely painful condition, and opioids are a mainstay of therapy. Many of our patients, though, due to the accumulated damage from the disease, go on to develop chronic pain syndromes. The role of opioids in that is less clear. And most chronic pain management, we would be switching to more non-opioid related therapies. But our patients are very hardwired to think, I have pain, I need my morphine. So kind of getting them to disentangle from that thought pattern can be a little bit challenging. We also know that opioids are involved in central sensitization, whereby your nervous system is altered due to the effect of opioids, and your pain sensing mechanisms are altered. So, sometimes giving opioids in that setting can be challenging, and again, trying to get patients to understand that that's a different type of pain, and that opioid is not necessarily the right medicine to take can be a challenge for us.
Sorry, Yeah, one here. Opioids. Dana Devine's first clinical paper was the use of D-dimer to identify who was truly sickling and who wanted their opioid fix. Is that still part of your armamentarium?
No, so, there's no, part of the problem is we don't have any good biomarkers for, who is truly sickling. Pain is pain to the patient, right? So if it's acute, if it's chronic, it's really, they need treatment. And so even if we think it's more of a chronic pain flare, often we will still treat it, at least initially, with a little bit of an opioid, just because we can't figure it out in real time.
I have two comments. One, in terms of chronic pain management, one of the problems is that the patients get opioids when they're in-house, and they're stopped, the patient's sent home on oral meds, and they recycle back to the emergency room within a few days. So the concept of tapering off the opioids and substituting nonsteroidals, we always start with nonsteroidals. And try to not get them in that cycle of breaking through because they're rebounding from coming off the opioids.
Yeah.
And not easy to do by any stretch.
Yeah, and definitely we always use a multimodal analgesia approach. So for patients that can have nonsteroidals, that is a key component of it, acetaminophen. And then patients who are presenting more frequently, that's, we have a pretty low threshold for investigating for chronic pain syndrome and starting them on the pathway for chronic pain management.
Yeah. The other thing is that although the FDA does approve these drugs in the U.S., does not mean that you will get the drug in the U.S. And navigating the insurance system is challenging at best. For example, we're approved to do lentiglobin for thal and sickle, and we can't get funding for egg harvest or sperm banking.
Yeah.
So, how do you navigate all this stuff? And the company doesn't have a plan. And so it can be very challenging, and we're all dying for this to happen and for gene therapy to be used because it's going to be life-saving.
Yeah.
Yeah, so this is from Sakara at VGH. The question is, what is the target LIC pre-SCT to ensure that the patients would tolerate busulfan with no significant VOD?
Yeah, so, for thalassemia patients, this is definitely a big issue. We know that, of course, iron overload predicts worse outcomes. As far as I'm aware, there's no target per se. In the trial, it was, probably around 5. We're generally happy if the LIC is 5 or less. But even if you have well-controlled iron currently, there can still be fibrotic damage from a history of poor iron overload. So we still use, there's the Vicenza score that was developed for transplant, so we still use that as kind of a gestalt of who would be at increased risk of having severe hepatic complications with myeloablative chemotherapy.